Welcome to the deep dive. Today we're venturing into a really crucial area for understanding children's health, metabolic and endocrine disorders. We've got a fantastic and really comprehensive resource here, a nursing review chapter just packed with need-to-know information.
Exactly. And
Yeah.
think of this as your guide to understanding how children manage fundamental things like their energy, their body temperature, and what happens when those finely tuned systems run into trouble.
Right. Our mission today is pretty straightforward. Pull out the most vital knowledge from this material, explain it clearly, and give you a solid grasp of these conditions without getting, bogged down in too much extra detail.
Sounds good.
So let's jump right in with something really basic but super important. Fever.
Okay, fever. So fundamentally, it's just an abnormally high body temperature. But what's interesting with kids and important to remember is that their temperature isn't always stable like in adults.
Oh, right.
Yeah, it can bounce around quite a bit depending on how active they are, their emotions.
Yeah.
Think about how red a toddler gets when they're having a tantrum,
Yeah.
what they're wearing, even the room temperature. It's partly because that internal thermostat in their brain, the thermoregulatory center, it's still developing.
That makes total sense. A kid running around outside is bound to be warmer than one who's just sitting quietly. So when we do suspect a fever, what are the key things, the signs we need to look for to figure out how serious it might be?
Well, the temperature reading itself is obviously the first piece.
Mm-hmm.
The normal range for a child, generally speaking, is between 36.4 and 37 degrees Celsius. That's about 97.5 to 98.6 Fahrenheit.
Okay.
And we typically call it a fever if it hits 38 degrees C or 100.4 Fahrenheit or goes higher. But, like you hinted, the number isn't the whole story, not at all. We also need to look for other clues the body's giving us.
Like the classic flushed cheeks and feeling warm, that sort of thing.
Precisely. Flushed skin, feeling warm to the touch, those are very common. You might also see diaphoresis, which is just the technical term for sweating a lot.
Right, sweating.
Or they might have chills. And behaviorally, a child with a fever might be really restless, or kind of the opposite. They might seem super tired, really lethargic. Looking at all these signs together helps paint a clearer picture.
All right, so we've gathered the data. We think there's a significant fever. What are the first steps? What should we do?
Okay, the main goal with interventions is really about supporting the child, making them more comfortable. First off, we monitor their vital signs and keep checking that temperature, usually electronically or however the facility does it.
Mm-hmm.
Then we look at their environment. Simple things like taking off extra clothes or blankets, maybe lowering the room temperature a bit, getting some air moving. That helps the body cool down naturally. A cool compress on the forehead can feel good too.
What about the old sponge bath advice? Is that still recommended?
Yes, but with specifics. A tepid or lukewarm sponge bath. Definitely not cold for maybe 20 to 30 minutes can help. You just gently sponge water on their skin, especially the back and chest. Evaporation does the cooling.
Okay, lukewarm, not cold.
Crucially, never use alcohol for a sponge bath. Alcohol can cause something called peripheral vasoconstriction.
Oh.
Yeah, it makes the blood vessels near the skin clamp down, which actually traps heat inside the body. It can be really harmful. And always recheck their temperature about 30 minutes after the sponging.
Good to know. And then, of course, there's medication. When does that come into play?
Right. Antipyretics, things like ibuprofen, can be given if they're prescribed by a healthcare provider. But it is absolutely critical. I can't stress this enough. Never give aspirin to a child with a fever unless a doctor specifically tells you to.
Because of Ray's syndrome.
Exactly. That risk, while rare, is serious. After giving an antipyretic, you'll want to check their temperature again in about 30 to 60 minutes to see if it's helping.
And hydration is always important when someone's sick, isn't it?
Absolutely vital. Encourage them to drink plenty of fluids, whatever they can tolerate, and following the doctor's advice. We also need to be really watchful for any signs of dehydration or electrolyte imbalances those essential minerals.
What would those signs look like?
Things like decreased urination, a really dry mouth, maybe changes in how alert they seem. Blood tests can also tell us about their electrolyte levels. And finally, it's so important that parents know how to take an accurate temperature, how to give medicine safely, and crucially, when they need to call their primary healthcare provider.
That's a really clear breakdown of fever management. Okay, let's move on to another really common issue you mentioned, dehydration.
Yes, dehydration. It's a very frequent fluid and electrolyte imbalance we see in infants and children, and they're particularly vulnerable to it.
Why is that?
Well, a couple of reasons. Their bodies are still developing, you see. Their kidneys, which help conserve water, aren't fully mature yet, so they're less efficient at balancing fluids. Plus, children actually have a higher proportion of their body water outside their cells in what we call the extracellular fluid space, and that fluid is lost more easily.
Ah, so they can get dehydrated much quicker than adults. What are the typical things that cause it?
Lots of things, unfortunately. Not drinking enough is a big one, obviously. Losing too much fluid through uh, diaphoresis, heavy sweating, or vomiting, or diarrhea. Those are common culprits. We also see dehydration linked to certain medical conditions like diabetic ketoacidosis, we'll get to that later, and also with significant injuries like extensive burns where fluid basically shifts out of the bloodstream.
The chapter we reviewed mentions a specific table, Table 30:1, for evaluating the extent of dehydration. What kind of details are in there?
Yeah, that table is super helpful for clinicians. It breaks down the specific signs and symptoms based on the degree of dehydration, mild, moderate, or severe.
Okay.
So it looks at things like how moist are their mucous membranes, inside the mouth? What's their skin trigger like? That's the skin's elasticity, how fast it snaps back if you gently pinch it.
Yeah.
It also assesses heart rate, breathing patterns, their overall alertness or level of consciousness. It gives you a systematic way to gauge how much fluid they've likely lost.
And when we're caring for a child who is dehydrated, what are the key interventions?
Well, first things first, you have to try and address the underlying cause, whatever's making them dehydrated. Then it's all about close monitoring. Watching their vital signs, tracking their daily weights, are a great indicator of fluid gain or loss. Carefully measuring their intake and output, how much they drink versus how much they urinate. Checking their urine-specific gravity, which tells you how concentrated their urine is. And constantly reassessing their level of consciousness, skin turgor, and mucous membranes.
And how do we get fluids back into them? I assume it depends on how bad the dehydration is.
Exactly. For mild, maybe moderate dehydration, oral rehydration therapy, ORT, is usually the way to go. This means giving specific rehydration solutions like Pediatric as prescribed.
Okay.
It's really important not to give sugary drinks like apple juice or sodas. The high sugar can actually pull more water into the gut and make diarrhea worse, and carbonation can irritate the stomach.
Good point. And for the more severe cases?
For severe dehydration, the child will likely be kept NPO nothing by mouth to let their gut rest. Fluids and electrolytes will be replaced intravenously, following the doctor's orders.
5E fluids.
Yes. And a critical point here. If potassium is part of that IV fluid mix, you absolutely must confirm the child has urinated recently and has good kidney function before starting it. Giving potassium when the kidneys aren't working well can be dangerous.
Got it. Check for peeing before potassium.
Exactly. Once they're rehydrated, you gradually reintroduce a normal diet. And just like with fever, parent education is key. Teaching them about the right types and amounts of fluids, the warning signs of dehydration, and when to seek medical help.
Okay, great. We've covered fever and dehydration, two really common, really important things. Now let's shift gears a bit and talk about some specific metabolic disorders, starting with phenylketonuria, or PKU.
Right, PKU. So phenylketonuria is a genetic disorder. It's what we call autosomal recessive, meaning a child has to inherit a copy of the faulty gene from both parents to have the condition. What's really key about PKU is its impact on the central nervous system. People with PKU lack an enzyme needed to properly break down an amino acid called phenylalanine. Phenylalanine is essential. We get it from protein in our diet. But if you can't break it down, it builds up to toxic levels in the blood, and that can cause significant brain damage, especially in early development.
What kind of levels are we talking about? What's considered toxic?
Well, normally, phenylalanine levels in the blood are very low, somewhere between 0 and 2 milligrams per deciliter. In PKU, if it's untreated, those levels can soar above 20 milli-GDL. That's a huge increase, and that's where the danger lies.
I know newborns get screened for a lot of things right after birth. Is PKU one of those?
Yes, absolutely. In fact, mandatory newborn screening for PKU is done in all 50 states here in the U.S. This early detection is just crucial because starting treatment right away can prevent the devastating long-term effects.
And what kind of problems could we see if PKU isn't caught and managed early?
In infants and young children with untreated PKU, you might see things like digestive problems, maybe vomiting, seizures, a very distinctive musty or mousy odor to their urine, and sadly, intellectual disability.
Oh, wow.
In older children who perhaps weren't diagnosed or treated effectively, you might see additional signs like eczema, increased muscle tone hypertonia. They might have lighter skin, hair, and eye color than their family members. That's hypopigmentation and sometimes hyperactive behavior.
So that newborn screen is absolutely vital. How does the testing work right after birth?
The screening test, usually a heel prick blood test, is ideally done after the baby has had some protein feedings, either breast milk or formula, for at least 24 to 48 hours. That gives time for phenylalanine levels to rise if the enzyme is missing.
Okay.
Now, if that initial screen comes back positive, it doesn't automatically mean the baby has PKU. It means more testing is needed, usually a repeat, more specific blood test, and further evaluation to confirm the diagnosis.
And if the first test was done very early?
Right. If the initial screen was done before the baby was, say, 48 hours old, they usually recommend a repeat screening by about 2 weeks of age, just to be sure.
And if it is confirmed, what's the main approach to managing PKU?
The absolute cornerstone of PKU management is a lifelong, very strict diet, low in phenylalanine. This means severely restricting or avoiding high-protein foods. Think meats, fish, poultry, eggs, dairy, nuts, legumes.
That sounds challenging.
It is. They also need to avoid the artificial sweetener aspartame found in many diet drinks and foods because it actually breaks down into phenylalanine in the body.
Wow, okay.
Alongside the diet, it's critical to closely monitor their growth, their neurological development, and their cognitive function. Regular blood tests track their phenylalanine levels to make sure the diet is working and they're staying within a safe range.
That sounds like a huge adjustment for families. What kind of support do they need?
Oh, immense support. It's a lifelong commitment.
Wow.
Ongoing follow-up with the specialized metabolic clinic team is essential. We need to encourage parents to talk about their feelings, provide genetic counseling about risks for future pregnancies. And education is massive, teaching them about the special low phenylalanine formulas that become their main protein source. Meticulously reading food labels, understanding which fruits and vegetables are lower in phenylalanine. Social workers often get involved too, helping families navigate the cost and insurance coverage for the special formulas, which can be quite expensive.
Yeah, I can imagine. The chapter also had a critical thinking question, and the answer really hammered home those key points: the diet, the monitoring, the education, and that crucial family support.
Exactly. It truly takes a village, a dedicated healthcare team, and a really committed family working together.
Oh, wait, let's move on now to another really significant metabolic and endocrine issue in childhood: diabetes mellitus.
Right. Diabetes. It's a condition where the body has trouble regulating blood glucose, or blood sugar, which is our main fuel source. The chapter focuses primarily on the two main types seen in children. Type 1 diabetes. This is where the body's own immune system mistakenly attacks and destroys the insulin-producing cells, the beta cells, in the pancreas.
So the body just stops making insulin.
Essentially, yes. It leads to an absolute deficiency of insulin. Without insulin, glucose can't get from the blood into the cells to be used for energy.
And type 2 diabetes is different.
Yes, type 2 usually involves insulin resistance. The body cells don't respond properly to the insulin that is being produced. Often this is coupled with a relative insulin deficiency, meaning the pancreas might still make some insulin, maybe even a lot initially, but it's not enough to overcome that resistance and keep blood sugar levels normal. It's like the locks on the cells have changed, and the insulin key doesn't work as well.
So insulin is the key hormone here, regardless of type.
Absolutely critical in both types, but especially type 1. The person needs exogenous insulin from outside the body, given by injection or an insulin pump, to allow their body to use glucose, and crucially, to prevent dangerous complications like hyperglycemia, high blood sugar, diabetic ketoacidosis, DKA, and even death.
How is diabetes usually picked up in kids? How is it diagnosed?
Diagnosis typically comes from recognizing those classic symptoms we'll talk about, combined with blood tests showing elevated blood glucose levels. A normal fasting blood glucose is usually somewhere in the range of 70 to 110 milligrams per deciliter, though targets can vary a bit.
Okay.
But it's really important to know, especially with type 1, some children are diagnosed when they present in a very serious state called diabetic ketoacidosis, or DKA. They might need immediate admission to a pediatric intensive care unit, a PICU.
That sounds scary. What are those classic signs and symptoms people should be aware of?
Yeah, the classic triad is often called the 3 Ps. Polyuria meaning peeing a lot, really frequently. Polydipsia being extremely thirsty all the time. And polyphagia being excessively hungry.
Peeing, thirst, hunger. Got it.
Right. You'll also see hyperglycemia, obviously the high blood sugar. Often there's unintentional weight loss, even though they're eating more. They might complain of being really tired, lethargic, maybe headaches.
Any other signs?
Sometimes the sudden start of bedwetting and uresis in a child who was previously dry at night can be a clue.
Yeah.
In adolescent girls, recurrent yeast infections, vaginitis, can occur because yeast likes high sugar environments. You might notice a fruity smell in their breath. That's from ketones, signs of dehydration, blurred vision, cuts or sores healing slowly, and sometimes even changes in their level of consciousness.
That's quite a list.
Yeah.
What about the long haul? What are the potential long-term effects if diabetes isn't managed well in childhood?
Unfortunately, chronic high blood sugar over years can damage blood vessels and nerves throughout the body. This can lead to complications like failure to grow properly, delayed puberty, more frequent infections, nerve damage or neuropathy, cardiovascular disease later in life, damage to the tiny blood vessels in the eyes, retinal microvascular disease, which can affect vision, and similar damage in the kidneys, renal microvascular disease, potentially leading to kidney failure down the road. It's really about protecting those small blood vessels.
And what about more immediate, shorter-term complications?
Yeah. In the shorter term, the big concerns are hypoglycemia, low blood sugar, and hyperglycemia, high blood sugar. Diabetic ketoacidosis, DKA, as we mentioned, is a major acute life-threatening risk. Coma can result from either very low or very high sugars, or DKA. And electrolyte imbalances, especially with potassium, either too low hypokalemia or too high hyperkalemia can also occur, particularly during treatment for DKA.
Wow. Okay, managing diabetes clearly involves a lot. Let's start with diet. What's the general approach for kids?
The focus really is on normal, healthy eating. It needs to be individualized based on the child's age, their growth rate, activity levels. There's usually no need for special diabetic foods or supplements unless a doctor specifically prescribes something. They just need enough calories for energy and growth.
So regular healthy food.
Right. The plan usually involves 3 balanced meals at regular times, plus maybe a mid-afternoon and a bedtime snack. Consistency is key, trying to keep the amount of carbohydrates, proteins, and fats fairly consistent from day to day at each meal and snack. Concentrated sweets like candy and sugary drinks are generally discouraged, and fat intake is usually limited, often to 30% or less of total daily calories.
I know carrying a quick sugar source is often recommended. Why is that so important?
Oh, absolutely essential. That's for treating hypoglycemia, low blood sugar, if and when it happens. Kids with diabetes, or their parents, should always have a readily available source of fast-acting glucose with them, like glucose tabs or juice.
Got it.
And remember, the diet plan needs to be flexible, considering the child's preferences, their lifestyle, cultural background, family resources, and involving the child in an age-appropriate way in making healthy food choices really helps with adherence and gives them some control.
Makes sense. What about exercise? How does physical activity fit in?
Exercise is great. It's strongly encouraged for overall health and helps with blood sugar control, but it does require planning. Increased activity usually means needing extra carbohydrates beforehand. Maybe 10 to 15 grams for every 30 to 45 minutes of exercise is a general guideline.
Okay, extra snack before playing.
Yes, and it's also really important to check their blood glucose before they start exercising. The exercise plan itself should be discussed with the child, considering what they enjoy and what's appropriate for their age and development.
Insulin therapy is obviously a huge part of this, especially for type 1. What are some key points about using insulin in kids?
Right. Well, for very young children, infants sometimes, the doses needed are tiny, so diluted insulin might be necessary. If that's the case, it is absolutely critical that it's labeled clearly and accurately to prevent serious dosage errors.
Very important.
We monitor long-term control using the HbA1c test, usually done every 3 months or so. It gives an average blood sugar picture over the past couple of months. The target is typically less than 6%, but again, individualized.
And what about when kids get sick?
That's a crucial time. Illness, infections, even stress, they can all increase the body's need for insulin. So insulin should never be skipped during illness, even if they're not eating much. That's a common misconception that can lead straight to DKA. If a child is going to be NPO, say for surgery, the insulin plan needs specific clarification from the healthcare provider.
What about the education side of insulin for families?
Education is just paramount. Parents and the child, as they get older, need thorough training on how to administer insulin correctly, injections, or pump use. They need to know the signs and symptoms of both low blood sugar, hypoglycemia, and high blood sugar, hyperglycemia, and exactly what to do for each.
Right.
They also need to be taught how to give glucagon, usually an injection for severe lows if the child is unconscious or can't swallow. Always have spare insulin available. And wearing a medical alert bracelet is a really good safety measure. The chapter also points to another section for more specifics on insulin types and techniques.
Home blood glucose monitoring seems like the standard now. How often do kids typically need to check?
Frequent monitoring is really the key to good day-to-day control. It gives real-time data. It's way more accurate than urine testing for glucose management. It does involve finger pricks, yes, and the frequency is prescribed by the doctor. It varies quite a bit.
Okay.
Education here is vital too. Proper technique for accuracy, hand washing before and after, understanding their specific meter, calibration, checking strip expiration dates. Accuracy is everything for making good decisions.
What if a reading seems off?
Good question. If a result seems weirdly high or low, the advice is stop. Reread the meter instructions, check your technique, check the strip expiration, maybe try a different finger, and retest. Don't just act on a reading that doesn't make sense.
Does urine testing still play any role?
Yes, but primarily for checking ketones, not for tracking blood glucose levels accurately. Ketones, remember, show up when the body is burning fat for fuel because it can't use glucose due to lack of insulin. High ketones are a warning sign for DKA.
So test for ketones when?
Generally, you test urine for ketones when the child is sick, or if their blood glucose is running high, say over 200 or 240 milli-GDL, depending on their provider's advice or as specifically instructed.
Okay. Let's dig into hypoglycemia a bit more. Low blood sugar, what defines it, and what are the classic signs?
Right, hypoglycemia, generally defined as blood glucose below 70 milli-GDL, though individual targets can vary. It happens from too much insulin, not enough food, especially carbs, or unexpected or excessive exercise.
And the signs?
They can come on quickly. Things like headache, feeling nauseous, sweating, tremors or feeling shaky, sudden fatigue or weakness, intense hunger, confusion, difficulty speaking clearly, maybe tingling around the mouth, feeling anxious or irritable. It can vary, though.
What's the immediate action plan if a child shows these signs or gets a low reading?
The chapter lays this out clearly. Step 1, if possible, check the blood glucose to confirm it's low. Step 2, give 15 grams of a fast-acting carbohydrate immediately, like 4 ounces of juice or regular soda, a tablespoon of sugar or honey, glucose tablets, hard candies they can chew quickly. Milk works too, though slightly slower.
Okay, 15 grams fast carbs. Then what?
Wait 15 minutes, then recheck the blood glucose. If it's still low, repeat the 15 grams of fast carbs. Once the glucose is back up in the target range, give a longer-acting snack with carbohydrate and protein, like crackers with cheese or peanut butter, especially if their next meal is more than an hour away or they're going to be active.
What if they're unconscious?
That's a severe hypoemergency. You shouldn't try to force liquids. You can rub glucose gel or cake frosting inside their cheek or gums. If you have glucagon prescribed and are trained to use it, administer it. Call for emergency medical help immediately, like 911. In the hospital, IV dextrose would be given.
Right, the chapter has those helpful lists of specific food items for treating lows, too.
Yes, very practical.
Now, the flip side, hyperglycemia, high blood sugar. What are the signs that glucose might be creeping up too high?
Hyperglycemia is generally over 200 milli-GDL. Again, check individual targets. Signs often mirror the initial diagnosis symptoms. Increased thirst, frequent urination, maybe increased hunger, blurred vision, feeling weak or tired, sometimes weight loss or feeling faint.
And when should parents call the doctor about high blood sugar?
The guidance is usually to call if blood glucose stays high despite following their plan, if they find moderate or large ketones in the urine, if the child can't eat or drink, if they're vomiting repeatedly, or if illness symptoms persist or get worse. Basically, when things aren't getting under control or there are signs of ketones or significant illness.
Let's talk about those sick day rules again. Managing diabetes when a child is ill seems tricky.
It really requires careful attention. The absolute key message: continue taking insulin. Illness often increases insulin needs, even if appetite is poor. Skipping insulin is dangerous. Always best to contact a healthcare provider for specific advice, though.
Okay, keep giving insulin. What else?
Check blood glucose much more often, maybe every 3-4 hours, or even more frequently if levels are changing fast. Check urine for ketones with each void.
And if ketones are present?
Notify the provider, especially if they're moderate or large. Encourage lots of fluids, mainly sugar-free ones, to flush ketones and prevent dehydration. Try to stick to the meal plan, but if they can't eat normally, offer carb-containing liquids or soft foods. Rest is important too. And call the provider for any warning signs like persistent vomiting, foody breath, rapid breathing, lethargy, or uncontrolled high glucose.
That brings us to the most serious acute complication, diabetic ketoacidosis, DKA. Can you explain what's happening physiologically?
Sure. DKA is a life-threatening emergency caused by severe insulin deficiency. Without enough insulin, glucose builds up sky-high in the blood, but the cells are starving, so the body frantically breaks down fat for energy.
And that produces ketones.
Exactly. Ketones are acidic byproducts of fat breakdown. They build up in the blood, making it acidic. That's metabolic acidosis. This whole process, high blood sugar, dehydration from trying to pee out the sugar, and the acidosis from ketones is DKA. It usually develops over hours to a day or two. Blood sugar is typically very high, over 300, and ketones are positive in urine and blood.
What are the key signs of DKA that someone might see?
You'll see the signs of hyperglycemia, plus often Kussmaul's respirations, those deep, rapid breaths as the body tries to blow off acid as CO2.
Okay, fast, deep breathing.
Yes. A fruity or acetone-like smell on the breath is common, increasing lethargy, confusion, progressing towards decreased consciousness. Nausea, vomiting, and abdominal pain are also frequent.
It sounds incredibly serious. What's the immediate treatment focus?
It requires intensive management, usually in a hospital setting, often ICU. The priorities are: 1. Restore fluid volume aggressively with IV fluids, usually normal saline initially, to combat severe dehydration. 2. Correct the hyperglycemia slowly and carefully with a continuous IV infusion of regular insulin.
Okay, fluids and insulin drip.
Right. 3. Monitor and correct electrolyte imbalances, especially potassium, which can shift rapidly as insulin starts working. We need to watch that very closely. 4. Correct the acidosis, which usually improves as fluids and insulin work. Vital signs, urine output, mental status, blood glucose, and electrolytes are monitored constantly. Oxygen might be given. And critically, check kidney function, urine output, before giving IV potassium.
Why is the potassium check so important again?
Because if the kidneys aren't working well, giving potassium intravenously can cause levels to become dangerously high very quickly, which can affect the heart. Also, need to watch for fluid overload during rehydration. Once the blood sugar starts coming down, they might add dextrose, sugar, to the IV fluid to prevent it from dropping too low or too fast. And of course, treat whatever triggered the DKA, like an infection.
Got it. The chapter also included some practical tips in a box, things like warming the finger before a glucose check, using the side of the fingertip, using lancets correctly, and choosing meters needing less blood to make monitoring less painful.
Yeah, those small things can make a big difference in daily life for kids doing frequent checks.
And as we touched on, there were those clear boxes summarizing the steps for treating hypoglycemia, listing the quick sugar foods.
Very useful, quick references.
And another box outlining when to call the doctor for hyperglycemia, plus that summary of the sick day rules, all very clearly laid out.
Exactly. Those summaries are great for reinforcing the key actions needed in those common situations.
And finally, the chapter wraps up with practice questions. Those are always helpful for checking understanding. Like one question on preventing lows during exercise emphasized that extra carb snack.
Right. And another reinforced that PKU affects the central nervous system and needs strict dietary control.
There was one about managing sick days with ketones, highlighting fluid intake as the priority.
And the safety question about checking urine output before giving IV potassium during dehydration treatment, super important.
Another asked about expected DKA findings, pointing to the fruity breath and decreasing consciousness.
And interpreting a normal PKU rescreening result as negative for the disorder.
The question on initial DKA treatment prioritized normal saline for the IV fluids to tackle dehydration first.
And the simple reminder about removing excess clothing after giving an antipyretic for fever to help cooling.
A good assessment finding indicating dehydration is resolving was a capillary refill time under 2 seconds.
And that select all that apply question on treating hypoglycemia correctly identified, giving fast sugar like honey and preparing glucagon, while avoiding giving insulin or encouraging exercise during a low.
So it really feels like we've done a thorough deep dive into this chapter. We've hit fever, dehydration, PKU, and a detailed look at diabetes mellitus in children, covering the core nursing concepts, assessments, procedures, safety points, priorities, and even reviewed those practice questions.
Absolutely. We've covered a lot of ground, hitting the crucial information for recognizing and managing these significant metabolic and endocrine issues in kids. It provides, I think, a really solid knowledge base for anyone involved in pediatric care.
Definitely. And with that comprehensive overview complete, here's something to think about. Considering how interconnected all these metabolic and endocrine processes are, what are some of the subtle ways one of these disorders might influence how another one presents itself, or how it needs to be managed in a child?